Good morning. It's a pleasure for us to be here with you today to share with you our experience and lessons learned over the last 15 months at SE Health, and to also discuss the perspectives and key role that nursing leadership at all levels in the organization played during the pandemic. My name is Nancy Lefebre, and I am the Senior Vice President and Chief Clinical Executive at SE Health, and I am pleased to be joined here today by Jillian Brooks, our Clinical Director of Wound Care and Infection Prevention and Control, otherwise known as IPAC, without whom we would not have survived the pandemic. We are also joined by one of our frontline nurses, Melanie Brown, who will speak to her experience as a frontline nurse providing patient care in the community. This slide provides you with an overview as to what we plan to cover over the next 45 minutes, and we really look forward to and welcome any questions or comments you may have at the end of the presentation. I thought I would begin by setting the stage and describing the context at SE Health for you. SE Health, as a not-for-profit charitable organization, is one of Canada's largest social enterprises impacting how people age and live well at home. We got our start with 4 nurses in the downtown core of metropolitan Toronto well over 110 years ago, and since then have grown into the national company we are today. We now have 9,000 staff that include nurses, therapists, and home support workers who provide 21,000 visits per day. In addition to our home care work, we provide and support many social programs that include residential hospice care for the homeless, and we are also engaged in capacity development in partnership with First Nations, Inuit, and Métis communities across the country. We have an established research center that is always tackling the tough problems of the day, and a number of healthcare career colleges educating the workers of tomorrow. I think it's fairly safe to say that responding to a pandemic of this size and scale was new for all of us in the healthcare system. In home care, we found that our experience was even more unique given our unusual context and environment. We experienced this pandemic in a multi-layered way as presented here in this slide, and I'll take a few minutes to discuss each of these areas a little more fully as they certainly influenced our response to the pandemic. First of all, I think it was likely the first time, certainly in my life, that we were not only working, but also living within a global context of uncertainty. This uncertainty caused a great deal of fear and anxiety for our staff, patients, and their families. The constantly evolving science, evidence, and information, and the impact that lockdown had on everyone's personal lives created an environment of significant change and strain. At the beginning of the pandemic, much of the focus was on the acute care system, and as a result, we found that resources and supplies, both human and PPE, were being diverted to this sector. This was followed by the significant impact COVID had on long-term care facilities and their residents, which caused a further diversion of resources. In fact, in the early days, we were redeploying our own home care staff to work in long-term care facilities to support the work that needed to be done there. As a result of this version and focus, there was a profound impact on access to PPE for the home care sector. We had a significant shortage that required us going to all types of extremes to obtain PPE to protect our patients and staff, which, as you can only imagine, further heightened the anxiety and fear of our patients and staff. Typically, for example, in our organization, we used approximately 100,000 surgical masks per year. Now, during this pandemic, we were requiring the same amount per month. Jill will speak further to the complexity of purchasing, managing, and distributing PPE in our unique environment. This trend in the healthcare context that really places home and community care at the bottom of the healthcare hierarchy continues to have an impact as our staff wait to get access to COVID testing, pandemic compensation, and most recently, vaccines. In the early days, home care was deemed unessential, and as a result, visits for clients were canceled by the funders in an effort to ensure capacity within the acute care sector and to support long-term care. As a result, we experienced a 30% reduction in our overall volumes, with some home care organizations experiencing up to as much as a 60% reduction. All of this resulted in not having enough work for the home care sector staff. This, coupled with childcare restrictions and the closures of schools, along with the support of SERB, resulted in more than 2,200 staff taking a temporary leave of absence at our organization. I'm sure you can appreciate with a 30% reduction in volumes, there was also a significant 30% reduction in revenue. This created a significant destabilization within the home and community care sector. We had to, as an organization, make some significant changes, or to be honest with you, difficult for our frontline staff to understand. I mean, how could it be possible that a healthcare organization could be downsizing and making significant changes in the midst of a global pandemic? Having said that, during wave 2 and 3, we began to see our volumes rise, not to pre-COVID rates. However, we did not simultaneously see a responding return of staff to work. So we now found ourselves in a human resource shortage, not dissimilar to other settings, where we do not have enough staff to care for all of the clients that need care. As a result, our staff are taking on more clients and families and experiencing greater workload demands that are further exacerbated when team members have to book off for reasons such as childcare or lack of childcare, isolation protocols, and waiting for COVID test results. Needless to say, innovation and creativity has been paramount in everyone's response and approach. Given our virtual, highly mobile workforce, we had to quickly change up our distribution of supplies, adapt our IPAC practices to include key issues such as how to create clean zones in cars, how to doff and don in unconventional settings, along with many other challenges that our unique contexts presented. And Jill will speak to those in more detail later in the presentation. Of course, there was a significant impact on our clients and their families. They too became fearful and began to cancel their visits as they did not want anyone in their homes for fear of contracting COVID. Overall, not receiving care and having missed visits for our patients had a significant impact on their own health and well-being. There was a greater reliance on informal caregivers, and a great deal of education and support was required for patients and families. Melanie Brown will be speaking to some of the strategies that she used as a visiting nurse to work with our patients later on in our presentation. Frontline staff had issues and anxieties in several areas of their life, both personal and professional. In many of the interviews we did with staff halfway through the pandemic, we learned that one of the greatest issues our staff had to deal with was the fear and anxiety that their own families had about them going out the door to work every day. Staff spent a great deal of time informing and educating their families in order to manage the level of stress and anxiety they were feeling in their homes. In addition to educating their own families, they also were addressing at every visit the fear and anxiety of their patients and families. Keeping up to date with the latest information and evidence, changing practices, and navigating this new environment created additional stress while on the job for our staff. From a systems perspective, our learnings can be really categorized into 3 key themes. First of all, the need to shift the attention away from surge capacity in the acute care sector to the rest of the healthcare sector that exists in the community that included long-term care, primary care, and home care. Secondly, nurses and nursing leaders were and are and continue to be well positioned to play key roles during the pandemic. Lastly, the view from the home and community care perspective demonstrated pre-pandemic fault lines that certainly have only widened during the pandemic. 3 key insights that we've learned have included, first of all, the identification of systemic biases and barriers that were exacerbated during the pandemic, which had a significant impact on the most vulnerable populations, such as the elderly, the homebound, and the homeless. Secondly, the significant fear and anxiety that I have spoken about that nurse leaders experience from staff, clients, and families, and the amount of time and energy that needed to be given to address this very real fear was significant. And lastly, the opportunity that the pandemic presented on the other side of the coin for significant learning, innovation, and capacity development. So given these key learnings and insights, we're now going to speak about how nurses and nursing leaders at all levels made a difference at SE Health. I'll speak to the impact from an organizational perspective. Jill will speak to the impact from a practice and clinical perspective, and Melanie will speak to the impact at the front line. So my experience with the pandemic was that it really shone a light on all of the great things about our organization and sector. It shone a light on the collaboration and the collaborative nature of working together, the willingness to step up to the plate and to do the right thing, the nimble nature of our environment and our staff, and the passion and commitment of all staff within the organization. Simultaneously, the pandemic also shone a light on the cracks in our system. However, I'm extremely proud to say that we did not waste this pandemic, but in fact became stronger, more effective, and resilient than ever. I have categorized the numerous activities and work that took place at SE Health into these 6 categories, and I will speak to each of them over the next 5 minutes or so. First of all, we went into communication overdrive and amped our communication up tenfold. Given that our frontline staff are highly mobile and geographically dispersed right across the country, we needed to use multiple vehicles and approaches to communication. Technology such as Teams, that actually we had in place since 2019, instantly became one of our key enablers to be able to connect with staff anytime, anywhere. Weekly meetings with our governance board, weekly town halls with all the staff and the CEO and myself as the leader of the COVID Command Center, daily COVID Command Center meetings, frontline staff huddles where various levels of management joined to hear what the frontline staff were saying and what they were dealing with, and to determine how to support them and the managers as well. COVID bulletins and the establishment of a centralized COVID internet center as the one true source of information, and changes related to practice and care were but a few of the changes we made to how we communicated and stayed connected with all staff. The leadership team also quickly shifted the power structures by having greater engagement with frontline staff and managers, supporting teamwork, creating mechanisms for swift decision-making by flattening the hierarchical structure, and empowering the staff by setting a tone of agility and autonomy to just make it happen. While a significant amount of work was occurring within the organization to respond to the pandemic, an equal amount of time was spent by our nursing leaders advocating for our patients, staff, and the home care sector. An interagency group was formed within the home care sector that had and continues to have regular meetings with the government to influence practice and protocols for home care, while advocating for access to PPE supplies, pandemic pay, COVID testing, and more recently, vaccinations for our frontline staff. While we have been advocating for years to undertake virtual visits in the home care environment, the pandemic provided a window of opportunity for advocacy that resulted in the creation of payment schedules and a surge forward with virtual visits for our clients within just 2 weeks of the onset of the pandemic. Within 4 to 5 weeks, we introduced virtual care into our daily practices. And while we were lucky to have the tools and technology already in place, it did require a significant amount of work to create the standards, the protocols, the education, and the support systems and tools to spread and scale this change in practice for our nurses and therapists, but we got it done. In addition to relation to advocacy, knowing the importance of ensuring the survival of the home care sector and the need for it as an integral part of the healthcare system responding to the pandemic, we engaged the public through a collective campaign called Bring Health Home, where we stressed the importance of home care and identified it as one of the safest places to be receiving care during the pandemic. At SC, we developed a people-obsessed strategy. This strategy is exactly what it says. We became obsessed with focusing on our people, our patients, and their families. We fast-tracked our employee engagement strategies and gave a great deal of attention to ensuring we had feedback and input from all of our staff at all times as we worked to create new tools and processes to address and take down barriers to care. We initiated an employment engagement survey, followed up by many focus groups and one-to-one interviews to come up with strategies and solutions to address any issues occurring in the work environment. As I previously mentioned, we shifted the power base to have decision-making take place at the right level, engaging all staff and leaders at the right time to ensure that quick decisions could be made and acted upon. We truly believed in leadership at all levels and the concept of leading from one where stands became absolutely paramount. A great deal of time, of course, went into supporting frontline staff and their patients and clients. A task force was established to determine the best vehicles for reaching out to our clients and their families to keep them informed of what we were doing in order to keep them safe, what we were doing to keep our staff safe, and what their role was to also keep themselves safe. Direct access to our employee assistance program, patient and staff access to our spiritual care program that also went virtual, and the development of a comprehensive health and wellness program were but a few of the measures we took to support our patients and staff. Our digital transformation office went into overdrive, creating dashboards, tools, and digitizing processes to enable more effective and efficient work environments. In addition, a nurse experience app was created that better enabled communication with the office for our nurses and the ability of the nurse to manage his or her primary caseload more effectively. Within 1 week, we moved all employees who worked within an office across the country to a work from home model, complete with the supportive technology and tools required to work virtually. This included all staff from our home office, such as finance department, IT, human resources, education services, to our service delivery centers that included management, schedulers, and coordinators, and customer service representatives. Our healthcare career colleges also went virtual, changing up their approach, tools, and vehicles for teaching and learning. It was absolutely amazing to see this type of change take place within just 1 week. A recent survey we undertook related to working from home indicates now that the majority of our staff are enjoying working from home and in fact prefer to work from home. So we're currently in the process of building a robust plan to support working from home, acknowledging that there are some processes, structures, and tools that we haven't put in place, given the speed at which we move working from home, that we'll need to enhance as we look to reduce the size of our overall office footprint over the course of the next year. I'm proud to say that we also found ourselves turning outward to the community as staff engaged in a hope and happiness movement, ensuring that all members of the community were cared for. We partnered with Best Buy and Google to get technology into the hands of those patients that were shut in and isolated so that they could communicate with their friends and families in order to reduce the isolation and feelings of anxiety and fear. Our foundation supported the distribution of over 5,000 warm blankets to those living on the streets and sheltered, or who were vulnerably housed, or for those just needed to know that somebody cared. Our volunteers jumped in to sew thousands of cloth masks that were distributed to our frontline staff to give to our patients and families to ensure they were protected. And our Liz Pause volunteer program went virtual, ensuring that those that were isolated had a visit from a furry friend virtually to brighten their day and keep them connected socially. I'm now going to pass this over to Jillian so that she can speak to all of the amazing work that was done from a practice and clinical perspective. So over to you, Jill.
Thank you, Nancy. So throughout the pandemic, especially during the early months, we saw a rapid change in practice and directives as new research and evidence emerged. This posed particularly challenging given the remote nature of our workforce and care delivery. However, in true SE style, we rose to the challenge, designing and implementing various strategies to ensure the safety and support for our patients and employees. I'd like to share with you today some of the key activities and strategies related to leadership, IPAC practices, education and knowledge translation, care support, virtual care and technology. Nurse leaders at all levels used leadership best practices that were previously established by SE to build relationships and trust, create an environment that was empowering, create a culture that supports integration of the latest science, lead and support staff in making rapid practice changes, and balance the complexities, values, and priorities related to the pandemic. As Nancy mentioned, leadership quickly shifted the power structure. When I look back and reflect on my own experience as a nurse leader, my role quickly evolved, and I was suddenly required to engage and influence colleagues and senior leaders, many of whom I'd not worked closely with before. In a pandemic, there's no time to slowly build people's trust and belief, and so the focus on close collaboration, achieving buy-in and confidence in my knowledge and capabilities was more key now than ever before. It was quite amazing actually to see how quickly different departments, teams and people came together to collaborate on the approach to implementing structures and tools, leveraging the technologies and practical solutions while still unleashing their creativity. SE Health professional practice leaders developed and integrated all clinical decisions using a framework that focuses on the patient, the provider, and the environment. This is known as the three-factor framework. It was developed by the College of Nurses of Ontario. During the early stage of the pandemic, the framework was used to guide decision-making, including PPE use, which I will speak more to in a minute. Leadership teams across the community regions and seniors living settings quickly addressed the rapidly evolving protocols and developed frontline champions to further support knowledge translation right at the point of care. This was particularly important for our teams working in congregate care settings, where a focus on point of care competency assessment and champion support was key. The COVID-19 professional practice priorities framework provided consistent direction and a set of activities for the entire organization. This included the implementation of IPAC competency assessments prioritized based on risk, PPE allocation based on care setting, and the development of protocols that reflected the science, evidence, and public health guidelines. The framework helped inform our processes for projecting the need for PPE and developing effective distribution channels across all our service delivery sites. As Nancy mentioned earlier, home care was deprioritized to receive critical PPE supplies during the first months of the pandemic. I'm just going to take a minute to really paint a picture of just how complex that became. Access to supplies was so challenging, our procurement team and other leaders worked day and night to source PPE from wherever they could. Of particular shortage was masks, gowns, and face shields. Nurse leaders collaborated with the procurement team to develop tools to predict how many supplies we would need and how much we could get. And we then had to amend and communicate our distribution plan accordingly. We did not have anywhere near enough to follow traditional best practices. And so we had to balance the evidence and science with critical thinking and a best guess approach to create strategies for use. At the beginning, we were only able to provide our staff with 2 to 3 masks per day based on factors, including care setting. We developed protocols for mask preservation, storage, and reuse, creating videos to support the interpretation and understanding. Distribution needed to occur frequently and often involved leaders meeting frontline staff in parking lots to deliver PPE. Our protocols and distribution approach remained dynamic, and as PPE became more available, we were able to increase the daily use allowance and communicate those changes. Looking back and comparing to where we are today, it seems almost unbelievable and demonstrates the true commitment and trust of all of our staff. We recognize the importance of screening practices, both for our employees and patients in transmission prevention, and the importance of having visibility to the compliance. This led to the development of digital screeners and supporting staff to integrate these practices right into their day-to-day processes. The dashboard enabled leadership teams to have visibility to the compliance with the screeners and the important processes, and enabled one-to-one follow-up with their staff for further education and support. A comprehensive education and training program was developed, and important resources to support practice were made available 24/7 through our COVID-19 mandatory protocol portal. The portal was updated regularly to reflect the evolution of evidence, practice, and access to PPE. The goal was to create a repository that staff could reliably consider that one source of truth in an otherwise extremely confusing environment. The remote and virtual nature of our workforce meant we needed to get creative with our approach to communication and staff engagement. I had the opportunity to collaborate closely with our internal communications and e-learning teams to develop various strategies and vehicles for information exchange, some of which Nancy mentioned earlier. From bulletins and forums to audio podcasts and animated cartoons, we shared information in multiple ways to reach and engage our employees. Training programs were developed, leveraging best practices in knowledge translation to implement new protocols and supporting their uptake and compliance. Competency assessments and reassessments became an integral part of the process, often utilizing technology to support virtual demonstration and return demonstration of PP donning and doffing practices. Our orientation program was enhanced to ensure that our newly hired staff achieved a thorough understanding of the protocols, the rationale, and were able to safely put them into practice. Pandemic confusion was intensified by the media and social media, which in the later stages of the pandemic led to fear and uncertainty about the safety of the vaccines. Leadership made sure that support was provided to respond to questions and hesitancy through various mechanisms, including providing information in a format that was really understandable and from reliable sources. The local leadership teams sought out every opportunity for staff to be vaccinated, and they supported the frontline staff to obtain an appointment wherever they were challenged. Our organisation provides services across all sectors, providing care to patients in their own homes, ambulatory clinics, long-term care and retirement homes, schools, hospitals, homeless shelters, and sometimes even on the street. SE nursing leaders develop protocols and processes specific to each of these settings that often prove challenging to support staff to safely provide care. Close your eyes for a moment and just try to imagine appropriately doffing PPE inside the doorway of a small, cramped apartment, or adhering to infection control principles while caring for a homeless patient underneath a bridge. Many of our employees provide care in long-term care and retirement home settings, a sector that we know the pandemic hit hard and where transmission was at its highest. The Ministry of Health implemented directives limiting staff working in congregate settings to one location only. Resources and decision support tools were created to help local leaders work through each situation, addressing the key considerations and completing risk assessments. IPAC competency reassessments were required every 3 months and were preferably done at the point of care, which was facilitated by a truly collaborative approach with our supervisors, practice coaches, and our frontline champions in the homes. Our established team of clinical practice coaches provided coaching and mentorship to our frontline teams and our new hire staff. A role that's predominantly providing support and coaching for our staff directly in patient homes, they quickly adapted to provide that support virtually and to build capacity. SE's clinical practice resource team, a team of highly skilled registered nurses, were available 24/7 by phone or email to support frontline staff while they were at the point of care. This was essential with the rapidly evolving evidence and practice changes, while providing a valuable touch point to ask the staff members, how are you doing today? The hierarchy of controls is clear that elimination and substitution are the most effective methods to reduce transmission, physically removing or replacing the hazard. SE Health had tested models of virtual care previously, and therefore once virtual care compensation was approved, the work of spreading and scaling virtual care became the focus. The scope of nursing practice has always included patient teaching and family engagement to support self-management and improve quality of life. And so now these elements of nurses' practice took on a greater imperative. The focus included developing tools and skills, leveraging technology, training staff in providing effective virtual care interventions, and supporting implementation and change management. This has been a significant change in practice for both the nurses and the patients. Real-time pandemic dashboards were developed to track key metrics that supported rapid and effective decisions. These metrics included patient and provider screening, patient COVID-19 status, IPAC competency achievement of staff, mask fit testing, and surveillance testing. I would like to introduce you to one of our exceptional frontline nurses, Melanie Brown, to share some of her experiences.
Thanks for the introduction, Jill. I'm happy to be here today to talk about nursing in the pandemic with SE Health. I think like everybody, we had a lot of fear in the beginning about the virus, about particularly the spread of the virus. if we were safe going into people's homes, if perhaps that was more risky, if we had enough PPE, if we had the right PPE. I remember spending a lot of time worrying about not only contracting the virus myself, but if I would spread it to our vulnerable patients. I think that weighed heavy on a lot of us. So it became very important that we had the proper guidance and early guidance right from the beginning and updated all throughout. We really became the source of information for the patients and their families. They relied heavily on us for, updates on how to use their PPE, on the spread of the virus. We became the go-to for families who weren't coming into their homes for their family members' homes for fear of spreading the virus. Something that really stood out for me was becoming the eyes and ears of the doctors. They, when they switched over to virtual care, they relied heavily on our assessment in the home. They were very appreciative of our assessments and our updates. I found the communication was much improved, which in turn was better care for the patients as well, provided better treatments, and kept patients out of the hospital, kept patients out of the doctor's offices, which was, I think, extremely important during that time, and something that I hope continues for the future. Another key development on the front line was the introduction of virtual care. I transitioned into virtual care very quickly with the help of a lovely 70-year-old patient who was very fearful of COVID, very fearful of, the spread and where I had been and that I could bring it into her home. So we quickly transitioned into spending our visits teaching, educating how to provide her own care, providing lists, putting together kits for daily dressing changes. The day that I arrived and was greeted with a 6-foot pole to keep our distance, I knew it was time to transition to a different method. So she was my first experience with virtual care, and we started, which once was 3 visits a week in person. We transitioned to talking on the phone 2 or 3 times a week, and more if needed. And in person, I don't think I saw her in person again for 1 to 2 months, and that was an outdoor visit. However, she did excellent care. If she had any real concerns, she knew I was available to speak to. She would send me pictures. We would talk on the phone, discussing the pictures. I was always available for live virtual team meetings or whatever she preferred. She indicated many times how proud she was of herself and how she felt very empowered by doing her own wound care. And happily, we got back on track towards the summer when we could do some outdoor visits. She still provided a lot of her own care, but I know that the biggest takeaway for her was she felt empowered to provide her own care again. And I think that was the big thing for me. Was virtual care reminded me that we get very comfortable taking over and being kind of invincible in the home, but actually our main job as a nurse, our basic job really is to educate and empower people to take care of themselves. And I really think that's what virtual care has demonstrated to me. I transitioned this into any patient I could think of, at least as a backup plan, and making sure they knew that I was always available by phone or video, but that they had the supplies and the ability to manage their own care if needed. So this went on a fair bit, and I think they were very appreciative of knowing that if I should become sick or they were sick, because they were equally as afraid to infect us as we were to infect them, that we had a plan B. and they always expressed how happy they were about this. And eventually they became comfortable with reducing visits and having more of a check-in type of visit, knowing that we were there if they needed us. So when I reflect back on what has been one of the most challenging years of being a nurse, it's been heartbreaking to see the effects of the isolation on our patients, and just the effects of being so isolated. And on the days that, it was a difficult day to be a nurse, to get out there, to put on all that PPE, to put myself at risk and potentially put our patients at risk, I think at the same time that is what got me through and others through, is just knowing that on the days that you just didn't know if you had it in you anymore, those were the days that the patients would tell you that you were the highlight of their day, you're what kept them optimistic, you made all the difference in the world for them. And I think it's just a great reminder of the difference we make every day, and how we impact everyone's life out here in the community. Back to you, Jill.
What we have been able to achieve to date during the pandemic is quite incredible. 4 million staff and patient screeners have been performed. Almost 1.8 million masks have been worn, and 32,000 cloth masks made by volunteers for our patients and families. Our nursing and rehab teams have performed more than 100,000 virtual visits, and over 3 million Microsoft Teams messages have been exchanged. As Nancy mentioned, we are so proud to have been able to provide 5,000 blankets for people experiencing homelessness in our community, and our virtual spiritual care providers spent more than 3,848 hours supporting patients, families, and teams across Canada. What really became clear during the pandemic was something that we've believed in for a very long time, which is that home is one of the safest places to be. Over the last 14 months, we've provided care for almost 1,600 COVID positive patients, yet only 2 were due to an exposure during care in the home, both of which were early on in the pandemic in the first few weeks. In addition, of the 346 employees that were diagnosed with COVID-19, 3/4 of them contracted the virus in their communities and not during interactions with our patients. Given that we perform more than 1 million visits per year, I think this really speaks to the rigor and adherence in our practices. Everyone at SE Health played a role in the efforts to ensure our patients, families, and staff remain safe, while continuing to provide outstanding patient care. The next step is sustainability and ensuring any lessons learned along the way are used to build an even stronger approach to care. We will continue to focus on the needs of our older adults and vulnerable populations, working together to keep people at home where they want to be. We'll continue to leverage technology and the tools that have been developed to empower frontline staff and stabilize the workforce through more full-time positions and competitive pay. And ultimately, we'll continue to provide personalized responses to the needs of our patients, of which they're entitled and deserve to receive. I'm going to hand it back over to Nancy now to share our next steps for future-proofing.
As we look forward into the future, there is much more work to be done in terms of not only sustaining many of these changes that Jill mentioned, but also for future-proofing the healthcare system. At SE Health, we have created a team called COVID, What's Next? This group looks forward as they anticipate the future needs in terms of things such as COVID packages of care for post-COVID clients and planning for the ongoing distribution of vaccines. They are keeping their focus ahead of where we are at today, learning from other countries and their lessons learned, and bringing that knowledge back into the organization to prepare us for the future. Mental health will continue to be an issue that we address, and COVID fatigue and feelings of languishing settle in, so that we require programs and services and supports for our staff, their clients, and families. Quality, risk mitigation, and compliance will continue to play a key role, and centralizing and standardizing these functions are a few of the activities we need to be continuing to move forward as we future-proof the organization and the system. As we look back over the last 15 months, we are astonished at what was accomplished both in spite of and as a result of the pandemic. In all our years of working at SE Health, never have we been more proud of our organization and the staff that work tirelessly at all levels to support and care for our patients and families. We have, in fact, gotten better through this pandemic. I truly believe that our focus and future direction is not just about surviving the pandemic, but in fact, creating a better new normal, not only for the home care sector, but for the entire health system, and more importantly, for a more resilient society. Thank you.
Thank you so much for joining us for this presentation today, and we look forward to responding to any questions you might have.